All right, hello everybody. Welcome to July office hours. Can't believe we're at the tail end of July here. Summer is here. All right, so we're recording as usual. So thank you all for attending, and we will have another jam-packed agenda as we normally do. And as always, if you have questions along the way, feel free to chime in or send something through the chat. Just want to confirm folks can hear me okay. That would be yes, no, maybe so.
Yes, we can,
Yes.
Travis.
All right, thank you. And then slide deck, yes. Folks can see it.
Yes, sir.
All right, and I saw a chat response. Yep, we got that going. Cool beans. All right, so we're ready to roll. All right, so we'll get going. And again, any questions, please, along the way, we can stop and pause and talk through stuff. So we'll have policy procedures as normal, children's updates, quality management, performance and compliance, assess tool, our friend, appropriateness criteria, another friend of ours, health home redesignation, another friend that's coming along our way in September, network training for data den, and then we have a website redesign that's occurring at AHI in the coming months that we'll talk about for folks as well. So policy and procedure. I don't know if Jess is on yet. If not, I can take it. Jess, you on? No, Jess yet. So I will take it.
I don't think she's on yet, Travis.
All right. So policies, procedures. So we have nothing that went out to the network this past month, but we have in process in the next few days assignments and referrals. We have comprehensive assessment, interpreter services, and eligibility and appropriateness. So those are in process of final review right now. Those are all annual updates. The one that you will see a lot of updates around will be eligibility and appropriateness. Those have a lot to do with the SES tool revisions and renditions that have occurred in recent months. So that's been tied into that policy. So those will be noted when that does come out for folks. So stay tuned for that. That will likely be in the next week that you'll see that come out to the network through our website, likely. Anybody have any questions on policies in general before we moved on? Okay, so moving on. General children's program updates. We just wanted to let folks know that AHI actually got a response from our HCBS audit that was submitted 9 months ago from last year's audit. That was had to be submitted. I want to believe it was at the end of September that we submitted that review, the cap for that review. We just got it back with about a week and a half response time that we had to get it back to DOH. So that was submitted and sent in. So we're waiting for that reply. It was hurry up, wait, and hurry up. And the sample size is going to be very small for this next turnaround. So that's not going to be incorporated into an audit for HCBS this year. So our next redesignation in 2025 is when HCBS will be audited. So that's going to be when we'll be audited for HBS in the next cycling. So we won't have a separate audit for that moving forward. It will be tied into our redesignation for children's. So stay tuned for our response from DOH. I don't know if it's going to be another 9 months or a couple months or a couple weeks, but the response for 2023 was just sent back in. So we're hopeful we hear a reply on that shortly. And then the quality policy will have some updates for surrounding the CAP response that we did just resubmit based on the responses that DOH did put in their reply that we received from them on the corrective action plan. So that's around the HCBS audit response from 2023. Jessica, I know that you're back now. I didn't know if there's anything that you wanted to add to this particular topic for HCBS for 2023.
Hi, can you hear me?
Yes.
Okay, perfect. Nothing I really wanted to add, as Travis said, we're going to be updating our quality policy surrounding the HCBS population. Currently in our our quality policy, there is a component that covers this population. However, we're going to expand on how quality and oversight works for this particular population of kiddos, because they required an increased amount of oversight from the lead level, from the CMA level. So that's going to be updated. And what I'm probably going to do is probably put a quick little 30-minute required training together to kind of review expectations for this population, and then what we're going to be looking for going forward, and kind of the corrective action process, because it will be slightly different than you're used to for the other populations that you work with.
Okay. Did anybody have anything around this particular topic for HCBS? All right, we'll move on.
All right, I just wanted to touch base on the comprehensive assessment real quick. So no changes right now, but I did just want to let everybody know a bit of good news for those folks that do work with children. We are part of a children's advisory group. It consists of a couple of health homes, some DOH representation, and the Health Home Coalition. And part of this work group is to look at ways that we can streamline and do away with some of the workflow on the children's side, some things that are duplicative. So one of those things we've been trying to work on is kind of doing away with the comprehensive assessment. It's still a required element, but we've been looking at ways to build the comprehensive assessment into the CANS assessment. So you'll have just that one assessment moving forward. We have pretty much everything worked out. We do hope to have this live Q1 of 2025, which, if you know anything about working on any task with DOH, that's extremely aggressive. But we have been making good headway with the red tape on that, talking to the UAS system. But what we're hoping to do is combine both of these assessments into one. So moving forward, if you work with children, you'll go into the UAS to do your CANS and do the comp at the same time, and really doing away with those duplicative questions. So if it's already asked in the CANS, you're not going to have to re-ask it again in the comp. So we're really hoping to cut down on the workload on the children's side. And I do believe this is a topic that I know it is a topic of conversation on the adult side. I'm just not part of that work group, but I know this is something they're also working on that end. But I just happen to be part of this particular work group, so I do have a little bit of insight on it. So that's just a bit of good news. As I know more, I will let everybody know. You can go to the next slide. Still no update with the core services billing policy. It's something that I brought to everyone's attention last month about how there will be changes in billing on the children's side and how the CBQ will look. It's still under development. I do have a meeting tomorrow with the state and with vendors to kind of work through the new CBQ, what the back end data will look like. It is going to be a bit complicated. So again, I do have that draft policy. I've not started working on a health home policy for us yet, just because we're already on our second version of that policy, and I don't want to put anything into writing that could potentially change, but I do want to keep it on here as a bullet point. So we just, touch base on it every single month. And then with that, just a reminder that if you're doing an interdisciplinary team meeting, please use the form that is in NetSmart. It's still per policy, not required, but it will be, and this is how we will be able to bill moving forward, because it will be a billable component. So if you have not used that tool, please start to use that. It's in the bottom left-hand screen of your NetSmart menu, and it says interdisciplinary team meeting form. Does anybody have any questions on that? All right, you can go to the next slide. High Fidelity Rep, I had a meeting yesterday with NetSmart and 2 other health homes. This is something that I've been kind of mentioning for a while because High Fidelity Rep did roll into under health home oversight as of January of this year. I just wanted to let everybody know because it was a question that I got from another CMA. Not every single CMA in our network will be required to do High Fidelity Rep. So if you work with kids, your CMA will not be required to serve High Fidelity Rep children. However, each care manager that works in the children's population will have to have an awareness of what High Fidelity Rep is, be able to explain to families what it is, and then have an awareness of where to send those youth and families if they do choose to pursue High Fidelity Rep. It is going to be flagged in the cans. So as you do the cans, you come out, you may have a recommendation for High Fidelity Rep. The care manager will just need to know what to do in that instance. More to come on that. The forms are in development in NetSmart. That was my meeting yesterday. We're trying to incorporate all of the High Fidelity Reps into existing NetSmart forms that we have right now. We're really hoping to only have to build one additional form in NetSmart and have everything standardized across the state. So if you do High Fidelity Rep currently with more than one health home, it'll be the same across all health homes. And there is some draft policy out there that I have given feedback on. But as there's more developing with this population, I will let everybody know. But I just did want to clear up that not every single CMA is going to be required to serve this population. You're going to have to go through a designation process. So if you serve Health Home Plus for adults, it's similar to a designation process for that, but it is much more intense. There's a lot of training and it's ongoing training and coaching to serve that population. Does anybody have any questions on that?
Jessica, Lori had her hand up.
Oh, sorry. Go ahead, Lori. Okay, maybe, can you hear me?
Maybe
We
she
can
changed
hear
her
you,
mind.
Jess.
Oh, okay. Oh, her mic's not
Oh.
working. Lori, if you have a question about High Fidelity Rep, you can give me a call or just shoot me an email. Or if you want to just type it in, we can always come back to it. I'm going to just jump to IRAMS real quick. The referral portal and staff compliance, just another reminder to please make sure that you are tracking all of your staff trainings in that portal for children. Also, there is a webinar tomorrow. On the 10th, I sent an email out with some tools that have been provided to me by the state. And the invitation for the webinar tomorrow. Every youth that is participating in HCBS will have to have their referrals input into IRAM. So if you have someone on a wait list or actively receiving them, all referrals have to be placed into IRAMs. I understand there are a lot of people when you pop into IRAMs that are appearing on your list that have been out of HCBS for a very, very long time. I am working with the state on how to try and clean those lists up. I also understand that the incorrect demographic information is appearing as well. K codes are incorrect, MCOs are incorrect. That cannot be edited. I did talk to the state about that, and it's pulled from various sources, and they couldn't tell me exactly what source they were pulling it from to go in and make sure it's correct there. So I understand it's a little bit of a mess, but please make sure that you attend that webinar tomorrow. That will be going over a short form on how to refer members. And Lori's question about High Fidelity Rep required training course like the one we already took previously. To my knowledge, you were never a designated High Fidelity Rep agency, Lori. You might have explored it. I think your agency was exploring it at one time. If you do move forward with the commitment, yeah, I think that's what happened. I think you guys looked into it and then you decided to not pursue it. So yes, Lori, it would be similar to those training courses. So it would start all over again. And again, they're not looking to designate new CMAs currently until early 2025. And again, that timeline could be pushed out, but it'll look similar, Lori, to what you started to look into. It is a very intense training, coaching, and supervisory process to serve that population. And from what I have heard, the training requirements are going to stay the same under Health Home. They're not looking to really change their training curriculum now that it's in Health Home.
Got another hand up, Jess. Angela, Tracy, I think.
Can't see any
Yep.
hands.
Hi, Jess. Just a question about IRAMs.
Yes.
So currently, only myself and maybe one other person in our agency has access to IRAMs. Are all the care managers going to have access to that?
So that's going to be up to whoever your IRAM's gatekeeper is and the supervisor in your workflow. So you can grant access to all of your care managers so they can put all of their referrals into IRAMs, or you can just have like one or two supervisory staff that have access, and they will just manage the referrals in IRAM. So that's going to be an internal workflow that AMH can decide what they want to do. It's not required
right,
for
thank-
everyone.
Thank you.
Personally, I'll just let everybody know internally at AHI, what we have done is just our supervisory staff have access right now until it is running like a smoothly oiled machine. Potentially, once that happens, we will add more care management staff into it. But for right now, we just have supervisors managing the referrals. So previously IRAMs asked at 2 to 3 per agency. Are they changing that policy? So that was for the staff compliance portal. That is to input all of your trainings. That's a different access to IRAM. So there's the referral portal for HCBS, and then there's the training compliance component, Lori. So for that training compliance component, you only want to have like 2 to 3 staff. For the incident reporting, 2 to 3 staff, like on our end, that's our supervisors, myself, and our HR department. But the referral portal is different. That could be all of your care managers or just a few. That would be up to you guys. Any other questions?
Jess, Allison asked in the chat if the training for tomorrow is labeled short form connection.
Yes, Allison, that's the training. And if anybody needs the invite for tomorrow, I did send it out on the 10th. So you can search that in your email or just email me and I will re-forward it again. Lori, I don't ever mind your questions.
I appreciate your humor though, Lori. That's funny.
We can go to the next slide. All right, update. Last month, I know we talked about CANS 2.1, that they were kind of looking at running everyone through the old algorithm and potentially refunding us some of those monies. They're still working through that. I have nothing to report on that, but I just want to keep it on the radar. This way we talk about it every single month, but there's no update there. I do have a positive update. Last month I talked about level of care billing. So anybody who had a youth enrolled in HCBS and they completed a plan of care from April 1st of 2021 to December 31st of 2024, you are eligible for that $200 reimbursement. That will be happening in August. So we do have a timeline for that and we have received our list. So those are all going to be paid out fee for service. And those are going to be billed out in August. And just a reminder, you may not get payment for somebody if your level of care, was done over 365 days, because per policy, the level of care has to be done every 365 days. If it's not done 365 days, it is overdue and you cannot get paid that $200. So in August, we will start seeing these payments come in fee for service. Does anybody have any questions on that? Angela, do you have a question or is your hand still just raised?
No question, sorry.
Okay, no, that's okay. Before I couldn't even see that or comments. All right, you can go to the next slide. Is a report. So, Lori, we did get a report for those youth that potentially can get that level of care payment, and I can send that out to everybody so you kind of know who to look for. Again, that's a report was just done during that time period of members who have had an initial, an annual, or let's say they were came out and they weren't eligible and another one was done. You can get one payment per 365 days, and it had to be done within that 365 days. And this report shows everybody, so it's not showing you just who's eligible. But if that's helpful, I can send that out to the CMAs. But it does not necessarily mean if a youth shows up on that report, you will be getting payment. But I can definitely send that out. Let me just make a note. Okay, moving on to SPOA's completing that HCBS level of care. I know that we talked about this last month. Again, another topic of conversation I just want to keep monthly on our agenda. We are still working through the process and giving feedback to DOH and OMH how we would like that process to look. I have seen some draft forms. It is looking like the process will be similar to CES, where we get the referral, hopefully from SPOA directly to us. I do not want the referrals from SPOA for these youth going directly to the CMAs, because as we all know, when we receive them from CS, there are a lot of errors. And I would like to be the first eyes on before I disseminate them out to the CMAs. I'm not alone. Every health home has asked that we be the first point of contact for these referrals. We'll see what happens, but for right now, it looks like it's going to be a similar kind of process to the CS process that we have now, just with SPOA. Again, modifications for technology. Modifications and technology for those HCBS waiver youth. We have no one receiving this service right now. I'm still waiting for an updated policy from DOH. The process has changed. As soon as I have something, I will let the network know and I will update the policy. If you are working with a youth right now that's enrolled in HCBS and you have just a thought crossed your mind that you may be requesting this service, please reach out to me, because the process has changed significantly to what is currently in policy. And then lastly, I had sent out an email blast to our children's network, just letting everybody know that early intervention has, it has always been a part of Health Home. However, you needed to be specifically designated to serve this policy. It was not working. It hasn't worked since 2016. The state has finally listened to our feedback. We can now accept youth that are enrolled in early intervention. They can come into Health Home. We can bill for them. We can treat them like any other Health Home enrolled member. And you would just coordinate with EI like they were any other provider. You no longer have to be duly designated to serve this population of people. We can serve and bill for our rate code, and they can serve their youth and bill for their rate codes, and everything will be compatible. So if you do get a referral for someone under 3 and you want to know if they're in early intervention, but is no longer a disqualifier. And Lori's just mentioning, of course, it has the process for EMADS, VMADS, and technology. Yes, it has, Lori, but it is a much better process. So it has changed completely, but we have taken the Department of Health completely out of the equation when it comes to accessing this. So it is going to be a much smoother process. So this was a good change. I just wish that they would give me policy so I could solidify that and give it to you all. Does anybody have any questions on this? All right. Do I have one more slide, Travis?
No.
No, I'm done. All right. That wasn't that bad this month.
Stay tuned. Okay, I'll take this. This slide will probably look familiar to everybody. We went over all of this stuff last month. Not to worry that the slide is on there. There's no new changes from what we went over last month. We just wanted to keep this on there, just to kind of remind everybody of the changes that we relayed to everybody. The CES is no longer required for those specialty populations, Health Home Plus, AOT, Health Home Plus Step Down, or those OMH Health Home Plus eligible members. Encouraging everybody to ensure that all of your members have the appropriate sub-programs. We do have that sub-program start end report that's available in DataDen. So just go in and take a look at that for your members and make sure that everybody has the appropriate sub-program so that their dates are pulling appropriately. Make sure that there's no future end dates. So if you do have a program open, you're not future end dating it to next year or whenever that person's Health Home Plus or Health Home Plus Step Down ends. You just want to make sure that that end date is blank so everything is populating correctly in DataDen for tracking purposes. Last month we went over the task feature, so just encouraging folks to utilize that to help them track when members are coming out of Health Home Plus and Health Home Plus Step Down so that you have an idea of when their CES tools are going to be due. Reminder that you are going to be keeping in the Step Down program for 12 months. So you'll still only bill on your HML for 6 months, but you will be keeping that Step Down program in for 12 months to coincide with the CES tool date. And then lastly, you can do the CES tool for internal tracking purposes for these specialty populations, but it's just not mandatory anymore. There is one additional thing that's not on here that I want to touch on that came up through just various research, and a CMA reached out. If you have a CES tool that is due and is pushed out because the member went into appended status and came back in, so say your CES tool is due July of 2025. And you go in and you do a CES tool this month anyway, even though it's not due for another year, and you get recommend continued services, that will pull, and this is not for the Health Home Plus population, this is just for your mainstream. That date will pull to MAP, and you will have to do a CES tool 6 months from the date that you did that. So just be mindful that you're following the due dates for your CES tools. If you have one that's been pushed out due to DSE, don't do it until that new date comes up in a year. Otherwise, you will be obligated to do that CES tool in line with whatever recommendation you received when you did it. So if it's not due, don't do it. Next slide, Travis. Reports, this is just an overview again of that initial CES due report. Anybody with an enrolled status that's been enrolled for 11 months or longer will be on there, and it will be all members that have not had their initial CES tool completed yet. Anybody that's returned from a pen status will have their CES date overriding the date that's originally populated based on the consent date, and it will display blue and show you the date based on when they have re-engaged. And that's just to look at it. Again, you guys can filter in the top if you want to see any members that have returned from appended status. You'll just go up to that top right and filter down on the ones that say 1, and it will show you anybody that's returned from append status. That way you can better keep track of anybody that has their CES date pushed out. Any questions on that? Oh, Angela, question? Or is the hand up from before? I don't remember.
I think she may have it up from before still, but
Okay. Okay, no
How do I
worries.
put it down? Do I click on it to get rid of it?
I think so.
I don't
I think you
know.
click
I
it.
have no
I got it.
idea.
I think
got
you
it.
click
There
it
you go.
once
It's
more.
down.
Yeah,
It's down now.
yeah, yeah. It
See,
says you
I'm
lowered it
pretty
now.
qualified.
And just to circle back on the CES dates, if you're doing that before they're due, when you have like it pushed out due to appended status, those new, like the new date will not populate in DataDen, just so you guys know. So if you have a date that's pushed out due to append and you do a CES tool, On the map file and in map, it's going to show that they have a CES tool due in 6 months or whatever, but it will not populate in Data Den because it's designed to override that feature if they have DSE. So Lori, I saw you said you messed it up. So if you have members that you think you messed it up for, and this goes for anybody, feel free to reach out and I can look in map and send you the appropriate dates just to make sure that we get any of that straightened out. Okay,
All right.
Travis, I think I'm done now.
Thank you, Taylor. Did anybody have any other questions for Taylor? All right. So what you guys are seeing here and probably read through already is a snapshot of an implementation timeline that DOH Lead Health Home had presented to the health homes through the Department of Health office hours last Friday about a timeline for revision of the CES tool and the appropriateness criteria for health home for New York State. That's going to occur over the coming weeks. That'll go into effect in September of this year for new definitions for the CES tool itself and for appropriateness criteria. And the reason being, even though we just got in place the billing blocks and the tools just went into play, and there were changes of the guidance over the last, 8 months since it all came into play late last year, is the budget that not this budget cycle that just went through that we were able to get pulled back, but the year prior, that the $30-70 million budget that got pushed through New York State that made cuts to health home has not been fully realized to this point to date, and the progress to this point has not been fully realized. And as a result, the Department of Health Home Program is looking to become more stringent on these tools and put forth more stringent criteria now to try and curb the criterion for health home eligibility to try and incur more cost savings. I'm trying to say it as politically correct as I can, so that we can realize those cost savings a little more effectively. I think it was said to the community that at best, maybe a third of the cost savings has been met. So that was what we heard. Not sure why this wasn't more transparent in the past. What does that mean? What that means is they're reiterating the fact that the health home is not long-term care management, that there's parameters being put in place to ensure that it is not long-term care management, that the eligibility criteria need to be met in order to be in the program, that it will be a time-limited service, and if that the eligibility and appropriateness criteria are not met for the duration of that time, that the person will not continue to remain eligible for services, and there'll be stopgaps to ensure that that's happening. So here's the time frame for that look. So what's happening right now, I'll show you on the next couple slides of what the proposed changes that the Department of Health put forward on the CES tool itself and the appropriateness criteria are versus what they put out for the community for us to be working with to what they want to make the change to be effective in September for those areas. And then there's a pushback from the health home community across the state and the Health Home Coalition right now on this draft that I'll be showing you to try and advocate for some different changes. So that's what's happening currently. Now, where it's going to land, I don't know, but there's some back and forth occurring. So I'm going to pause quickly before I go into what those changes are, just to get a response. Again, it's to put a time-limited scenario on the health home program so that's not long-term care management is the intention. Thoughts, comments?
So can you hear me, Tyler?
Travis, yes.
Or Travis, I'm sorry. So this is Jackie Jackson. My question is, I guess I mean, I feel a little confused about, is that why there's such a push to get rid of the lows? And then with that being said, we seem to get a lot of lows through the door. So I'm just trying to figure out how this is gonna work.
Yeah, I think I think that's the gazillion dollar question, Jackie. I think there's a big shift out there on, community health worker concept, that model. There's the social care network model with the social care
Yeah,
navigator, that whole model, which is a lighter touch. That
right,
when that model goes into play, once those awards go out across the state for regions, it's to link Medicaid recipients in the community on a lighter touch that aren't as high risk, quote unquote, to get those community resources intact, to help prevent them becoming more high risk. If they do, in fact, need a higher level of support, then they may qualify for a program like a health home or a more intensive care management model. That's where those eligibility assessment criteria come into play, right, to determine
right,
what avenue they may go. So I think that's where these models are starting to
right. Well,
define. I think it's going to
yeah,
cost more money in the long run, Jackie. To be honest with you,
yeah,
the state's going to spend more money in the long run, because these folks are going to be they're going to be disenrolled. They're going to be out there in a bubble. These other models are going to be set up. Where are
yeah,
they going to go in the meantime, right? In the end, they may get what they need, but until that time comes, they're going to be out there going in and out of services, getting bounced around, and it's going to cost the
right.
system more money. Is what it's going to come down to. My perspective, anyways.
And what's another confusing concept, I guess, is we we have these, we got to get the lows, we got to rotate them, get them in, provide the service, and then discharge. However, the paperwork is just so much to bring somebody in short term that I can
Yeah,
see how it would be a deterrent. I mean, it seems, I don't know, there's just so many things that are just mind boggling.
yeah, yeah. I think it's the eligibility piece is the big question now. What defines eligibility? What are the criteria? And
Right,
I think that's where the state's really looking to tighten it. Whereas in
right.
the past, you could really find a lot of ways to enroll somebody into the program. It was a lot looser, I guess you could
Yeah,
say, to get somebody in.
yeah,
And the DOH is realizing that that was the case, and they're starting to make it to where that's not the case. And it
okay,
was also the case in the past where you could enroll someone and they can remain enrolled indefinitely in many instances. And the state's realizing that that's not what the intention or what they wanted the intention of the program to be. And that's why you hear, this is not intended to be long-term care management. There's
right.
other models out there that are intended to do that type of level of service. And so now there's steps being made and taken to try and transition that model. And it's
Right.
painful on some
Right. And I
instances.
think some of the referrals that come across my desk um, don't seem to meet criteria after I, look it over with my supervisor. It's like, well, when I call them, well, what do you need? Well, we just need to fill out paperwork for SNAP. That's all you need? Yeah. And so I'm going to pass that on to a case manager that has to do hours of work. I don't know. It's mind boggling.
Yeah. And that's the big issue we have as well. There's a lot of issues with this, obviously, especially for those of us that have been doing this a long time and have lived through a lot of it. and those who are getting into it and are living through it.
Right.
That administrative burden, it's not going away. It's not making it any easier. And you know, the Department of Health is not taking a lot of steps to address that yet.
Yeah.
Keep saying they are, and there's been a lot of advocacy toward that, but it's just not given yet. It's not, there's not a lot of relief yet there. There's a lot of fight and advocacy for it. We're just not seeing a lot of it yet relieving. But yeah,
Thank you.
I hate to be a bearer of bad news with this. You know, health home's not going away. There's too many. It's not. There's too many people out there that need the service. It's a justifiable service. The length of time somebody's going to be in a program, that's what's being impacted. The eligibility of what's going to qualify somebody to be in a program for how long is what's being impacted. That's the difference. So an organization, how you diversify your business model is what's going to be impacted. So if you're an organization, is all you do is serve low acuity adults, you might want to look at your business model a little differently moving forward. If you've diversified your business model or are working on doing that, you're going to be in the game, right? It's different. It's a different look now than what it was 2-3 years ago. It's just you have to look at a different business business model wise. And unfortunately, you know, we're working with people. We're not working with widgets, but there is a business side of it. In order to continue to do the work, we have to be able to sustain to be able to do the work. So, you know, the program is not going to go away. It's just how it's set up is going to look different. And wouldn't it be tied to the SCN if it was going to go away? It's a big proponent of the SCN work.
I think there were some questions that people put through. I don't see them now, but
Yes, Travis, there's
Yeah.
comments and questions.
All right, where did they start? What we got?
So Trisha asked, so how long after we discharge people can we re-enroll them if they need service again? And
So-
Lori said, I think they'll have to have an event that justifies, which is accurate.
Yeah, so that's, you know, that hasn't, that is pretty accurate. That hasn't been like a clear defined thing through DOH. We as a lead health home has taken the stance that, you know, we want to make sure somebody's eligible and appropriate for services. So we want to do that check as a lead. We shouldn't have people just disenrolling from one CMA and the next one picking them up the next day, right? Are they truly
Yeah.
eligible for the service still? Is what it comes down to, right? And that's where this appropriateness and eligibility criterion come in. Was there a circumstance that led them to continue to be eligible for this service? Was there an event that occurred that continues to make them eligible? So it shouldn't be just, oh, the hell with you, I'm out of here, or we can't work with you anymore. I'm going to go to Joe Blow down the road and they'll pick me up. It's so there's got to be a check and balance in place. So that's going to be some manual check on the lead end. And some research that's going to have to happen in order to spot check that until we can get more of a more thorough system in place to do that. That's not a perfect science yet. That's got to be worked out better. But until it can get to be a better process, we've got to do our studying, right? We got to look into it.
And
Anything
then
else?
Tom asked, is there a DOH policy that defines health home care management as short term? I couldn't find any. Can someone help me find it?
Is there a policy? I don't see a policy on that yet either. No. I think DOH is saying they're working on something. I think the CES tool is what's being put together right now, Tom. I think you're going to see in this proposed next couple slides what's going to define a person's continued ability to be in a program once they have gone through the CES tool exercise, once they've been in for a little bit.
And Trisha asks, are they coming up with different case management pilot programs?
I've seen or heard of. Jessica Taylor, if you heard of anything, I haven't heard or seen of any other pilots.
No, not on the adult side. On the children's side, we do have that high fidelity wrap, so they're actually expanding children's services. And with these proposed changes that Travis is about to go through, we have on the children's side, we've advocated for all parties, but really we want to make sure that none of these changes to the appropriateness criteria to kind of tighten the reins and right size the program on the adult side. We've really tried to advocate that none of these inadvertently affect children's enrollment because the intention of this is not to affect children and their enrollment in the program. So anything we thought could inadvertently affect the children's population, we have asked them to not put into place. So on the children's side, they're expanding. On the adult side, there's really no pilot programs that I'm aware of, other than adding some more step down options with that community caseworker for that step down to the SEN work.
Yeah, and that's not tied to Health Home necessarily. It would be like a parallel if it goes into play. So community health worker role, an organization would have to adopt that as a service delivery of its own, if you will. So it's not like a community health worker that's a Health Home care manager role, if you will. So it's like its own separate thing within an organization. It's not a billable health home code, I guess is what I best describe it as. These are all good questions. Anything else before I start going through the proposed changes that DOH has?
No, that was it.
Okay. All right, so I'm going to knock the chat down here, Hannah, if you wouldn't mind just so I can read through these changes for folks.
Okay.
If you could just keep telling me if there's stuff that pops up. So on the left side this is the CES tool stuff. So this is for the adult population. The current stuff that's in place is on the left, and the updated stuff that's being proposed by DOH is the right side. So on the left, on the top left-hand side is what's currently in place, and they're looking to wipe it out on the right-hand side. So the member or guardian unable to appropriately navigate the healthcare system for the member's chronic condition, DOH is proposing to take that healthcare risk out. So they're saying they want to take out that member or guardian is unable to appropriately navigate the healthcare system for the member's chronic conditions. They want to take that out as a factor when going into the CES tool and looking at that as a significant risk factor. The next one they want to take out is the next healthcare risk is member has not seen their provider in the last year. They want to take that out as a risk factor as well. For healthcare risk, member does not have healthcare provider specialist or treat a chronic health condition. They want to change that and says member does not have a primary care provider and or for members with single qualifying condition or behavioral health diagnoses, member does not have a specialty provider needed to support the treatment of those conditions. So they want to really change it to primary care and or single qualifying conditions, behavioral health diagnoses, specialty providers in place to support the treatment of those conditions, to really bring it to provider-related diagnoses support. Change in guardianship caregiver within the last 3 months. So it said 6 months prior. They want to change it to 3 months. So it's going down to 3 months versus 6 in the next bucket, if you will. For the bottom category, readmission recidivism risk, they want to change that from last 6 months to 3 months as well. So I'm changing those. So I just wanted to pause there. There's some big changes here in these first handful of areas.
Lori had asked before you started, is that going to fall on to agencies that receive OMH funding?
I
don't-
think
I
she's
don't-
talking about the community health worker.
Oh.
Potentially, is that, I don't know, she can't, her mic's not working. I think she's asking if, the community health worker would go under CMEs. Okay,
Yes, that's what she was talking about. Yep.
okay.
I,
Go ahead, Travis.
my understanding is that would be a service you would have to, I don't know if it would be under OMH specifically, Lori. I think it's a service that's offered that was approved through the budget process. That if you were interested as an organization that you could apply for. There has been a rate established to go with it. And you would set that up for your organization if you're approved to provide that service. I don't know if it's specific to OMH or not, though.
I believe it's DOH, the community health worker, I believe, falls under the purview of DOH. From everything that I've seen, but like Travis says, you have to apply to do that program. You bill, I believe it's in 15-minute increments.
Yes.
But
Yep.
as long as you meet the qualifications your agency does and the staff do, I believe anybody can apply to provide that community health worker program.
Is there anything else, Hannah?
Are you saying that this is what the Department of Health says on their website about Health Home?
I saying?
No, Tom put in the chat, many are unable to find providers and services, which makes it hard for people to get well and stay healthy. New York State's Health Home program was created with these people in mind. The goal of the Health Home program is to make sure its members get the care and services they need. So I think what Tom is saying is what is on the DOH website contradicts what they are putting on this CES tool,
Oh,
which is true.
understood. Gotcha.
Trisha, it says it's going to become a huge cost to the healthcare system when we discharge these people. Absolutely.
Yes.
And Lori says, my other comment about primary care provider, most PCPs do not want the role of primary for mental health. However, do because a health home care manager is linked and there's a limit of mental health providers. Also very true.
Yes. No, I just want to say I'm not sure where these recommendations that DOH that put forward are going to land. This is just what has been proposed right now. We as a lead want to be transparent with our network. That's why we're sharing this with you. As you can see, it says draft on here, but we think it's important to be transparent, and that's why we're sharing this information. But it's happening. I mean, where it's going to land, we're not quite sure, but these changes are coming. And it will be happening in September, and we know that much. You're welcome. We value everything you guys do. We're all in this together. This is it's very upsetting. Any other questions on this particular slide? All right, so this is the next slide for the CES proposed changes. So you see on here, they're changing from 6 to 3 months from release from jail, prison, or justice program within 6 to 3 months. The next section, they're looking to remove, or it's being recommended to remove. I should stop saying they. It's being recommended to remove member as fewer than 2 people identified as support by the member. So it's being recommended to remove that category. It's also being recommended to be removed. Member does not have needed benefits, SSI, SNAP, etc. That's being recommended to be removed as a category. It's this particular category next is being recommended to change to say recent institutionalization or nursing home placement of the member's primary support person within the last 3 months, then there's no other person to provide the same level of support. So they're saying it's not nursing home placement of members' primary support. They wanted to say within the last 3 months, and there's no other person to provide the same level of support. So they're putting the time limit on it and no other person to provide support. And then treatment non-adherence of risk, member and care team report non-adherence within the last 3 months. So those are the proposed changes on this particular section of the CES tool. Anything, Hannah, that came up in the chat for there?
Just that it's gonna be very difficult to keep people enrolled.
Agreed.
That's it.
Okay.
Sorry.
Appropriateness criteria. I'll shift over to that. So these are the revised codes that are in draft. Jessica made comment that really a lot of advocacy not to impact anything with children around it. There is a potential slight touch on appropriateness criteria. Adverse events risk. There's been some language around that, and or direct referral from Child Protective Services, Preventative Services Program, county and local departments of social services, administrative for service, children's services, and my city foster care agency, special ed program, schools. Example, children's suspension, truancy grade, failure, repeat grade, summer school. And that was the big thing with that particular appropriateness criteria for that code 13. The next category, code 19, a member or guardian is unable to appropriately navigate and connect to. That was changed to be specific to children. Code 20, health risk, member does not have a primary care provider and or for members with single qualifying conditions or behavioral health diagnoses, member does not have specialty providers needed to support the treatment of those conditions. That was changed from member does not have a healthcare provider or specialist to treat chronic health conditions. So that was drilled down quite a bit more specific on that particular code. And that's for both populations. And then code 22, recidivism and readmission risk was included for emergency department for adults. Anything on this particular slide, Hannah, did anything come up on the chat?
No.
Okay. And then on the next one, code 27, I should say it's been recommended. I keep saying it's been recommended to take this particular criteria out, which was member has fewer than 2 people identified as a support by the member. Code 30, more specifically, will be added to types of entitlements that are applicable under this code. DOH is seeking health home feedback by 7/12 on the most critical specific entitlements. It will be included 4/6 of the most critical elements. That's partially what the coalition and health homes put in their feedback that has gone back to DOH. Code 31, within the last 6 months, and there's no other person to provide the same level of input. This is around institutionalization or nursing home placement of their primary support person within the last 6 months. and no other person to provide the same level of support. Then code 36 was proposed to be taken out. It was direct referral from Child Protective Services or Preventative Services Program, and that was specific to children.
I just want to clarify that that was taken out because it's combined with another code. That's not being removed for kids. They just combined it and actually expanded upon the first code that we went over. So that was the only positive to come out of this. Again, capturing more of that youth that we work with, and those direct referrals from the foster care agencies, DSS, CPS, and we know that a lot of youth that we work with have educational issues that really doesn't quote unquote make them eligible for health home, but we really wanted to make sure it made them appropriate for health home.
Thank you, Jess. Is there anything around what I just talked about? Anybody wanted to talk further on? We'll absolutely keep you all posted as we know more. Again, September is when the final changes will go into effect once we know what they are. We're supposed to know in September. In August, we're supposed to know what they are. We don't know what date in August yet.
I can take this, Travis. Nobody has any questions.
Okay. Thank you all for
So
bearing with us. I appreciate
Yes.
it.
this slide seems very straightforward, and it is, but we just wanted to throw this on there because we did do a consent audit last month that went out with the quality notebook. And I noticed some pretty glaring issues network-wide with 50/55s. So I just wanted to reiterate that the form, all DOH forms need to be filled out correctly and in their entirety. Make sure that you're putting AHI or Adirondack Health Institute as the health home name. There's 2 lines where it goes on the 50/55 on that first page. You're putting Hicksney as the Rio. Make sure that you have your MCO, if applicable, PCP, and your own CMA listed on the 50/55. And then a reminder for anybody that's using a pre-filled form. So if you already have providers typed up on an existing form and you're having members fill that out and grant consent to those entities, if it's pre-filled, members need to be initialing next to each of those pre-filled entities that they're consenting to. If they are just writing them in and it's not a pre-filled typed up form, then that's fine. They don't need to initial unless there's a change. But if you are using a pre-filled form upon initial enrollment, they do need to initial next to each of those entities that they're consenting to. Did I miss anything on that, Jess?
No, you got it.
Okay. Oh, one more thing. When you are updating the 50/55, make sure that if you're obviously you're only updating page 3, make sure that you're uploading the entire document again into your attachments, not just page 3 updated. The whole document needs to be in there. Okay, I think that's it, Travis.
Thanks, Taylor. All right, redesignation. Oh, Lori had clarity on that. She had, was that a question or
She
There
can't
she
type
is.
as fast as she's thinking.
when updating only page 3?
Yes, that goes for any of our consent forms, children's forms too. If you're only updating one provider, the entire consent form has to be re-uploaded into NetSmart. Yes, Allison, you want to always add Hicksney to the 50/55 because that also covers that connection to NetSmart for alerts. Yes, Lori, upload page 1, 2 of the original and then upload the updated third page, all as one document. That's correct.
Just for clarification, Allison, the Rio or Hixney doesn't go on the page 3, the provider page. It goes on that page 1 where I think there's 2 specific lines where it asks for the Rio name. You just write in Hixney on those lines.
Oh, sorry, I didn't see that second half of that question. Also, just to cover the Hixney component, so the Hixney, yeah, should be on page 1. If you're reading through the consent form, everyone should read a blank consent form. You're putting Hixney, that allows for those alerts to get into NetSmart. If your agency has its own connection to the Hixney portal, you then also have to have a consent form to access Hixney. That has nothing to do with AHI, and our 5055 does not cover your portal access. So you do want to make sure if you have your own portal access that you have your own consent form.
All right, thank you. All right, redesignation, I mentioned it's coming. We actually just got our entrance packet yesterday evening sent to us. So September 3rd will be our entrance meeting or conference with DOH and OMH and the AIDS Institute and all the other folks that are going to be doing our audit. So we're getting our stuff together starting now to get stuff. We got to do a self evaluation and get that all put together. We've already submitted a policy manual to DOH. So that's been sent in on our adult program. So we've already got some stuff underway. But anyhow, I mentioned this before, part of our redesignation review is domain 3, which is a huge part. It's 60% of our overall score is audit. So that's a sampling across our network of records, SINs that are pulled. We actually just received the list. It was actually last night as well. We downloaded it this morning. So we have our list of SINs that got pulled. So we got that a little over a month out, which was very good since last time we didn't get it before the actual redesignation. So we know who we got pulled. So we'll be reaching out to those of you that got pulled from your organizations. What we're asking, if you would, is to use the AHI audit tool that's located on our website. If you haven't already pulled it off there, there's the link. If you could go and do a review of the audit for the SIN that you have that got pulled, if it's tied to your organization, we would greatly appreciate it. We will also be doing a review. And just in general, do some spot checks if you would. We really want to have our best foot forward, obviously. Our score as a lead is a reflection of all of our work as a network. And we want to do well. I think we will do well, but I also want to make sure we put our best foot forward to do well. So we'll be in touch. To those of you that did get a sample pulled, it was a good representation across our whole CMA network. So many of you will be notified shortly. Thank you, and we'll be in touch on that. But I'm really glad they reached out ahead of time, so that's good. Data then, we got July 25th. What's today? 23rd, 2nd? I don't even know what today's date is. 23rd. So 2
It's
days.
in a
We
couple
got,
of days.
yeah, 2 days. We got 10 a.m. Taylor's going to be doing a nice review of Data Den for folks. Do a nice walkthrough. We wanted to throw out there, if anybody wants another training to be offered, let us know. We can do a second training for the network as well. And get another date out there for folks. And lastly, this is when you click on our health home page, this is the first thing that'll come up, and then it goes off to other things. Our AHI website is going to be going over, it's going to get an overhaul done because we got a new vendor that we're working with, a third-party vendor for our website. So as the year goes on, it's going to start looking different because the whole website itself is going to be overhauled. So you're going to start to see some changes in the coming months. So if it does impede your ability to get in and do what you need to do, please accept our apologies ahead of time. If you can't get to something that you want to or need to, please let us know, and we will make sure you get what you need. But we will have a nicer, better looking product that we think will be better for you all, more user friendly at the end of the day once it is all done. And we're hopeful by the end of the third quarter, I think was the ultimate goal, that it'll be up and running and in good shape for everyone. And that was all we had today. Not that that wasn't enough, I know, but didn't know if anybody had anything else they wanted to talk about. Jessica asked if data den training will be recorded. Taylor, do you want to record the data den training?
Yes, I will be attempting to record it. It's on my radar to record it. So if somebody that's on the training or wants to remind me when we get on, that would be very helpful.
We will make sure it's recorded.
Yes.
Anything else anybody had?
Real quick before we hop off, it's Jessica. I just wanted to let everybody know that, again, like Travis mentioned about redesignation, it is for adults only. We are only having an adult redesignation. Next fall will be for just children. So it's just adults too. We just got the information and everything after 5 o'clock last night. We downloaded it this morning. Taylor and I are going to parse out the list of selected members. It does not come in a digestible form to most supervisors, so we will have to put a list together, and we will be letting you know what records from each of your CMAs has been selected, and those would be the records that we're going to ask you to review. And then like Travis said, Taylor and I will be concurrently reviewing that list as well and be reaching out on items that need follow-up. So that list will be coming to you. We just have to put it in a much prettier format before we send it out to all of you.
Thank you, Jess. Well, as always, thank you all for everything you do. And I hope you all enjoy the rest of your day. And if you have some time off coming up, enjoy. And we'll talk with you all soon. Take care.